Goldman applanation tonometry is based on the invert-Fick principle, which states that for an ideal, dry, thin-walled sphere, the pressure inside the sphere P equals the force necessary to flatten its surface F divided by the area of flattening A, i.e. P equals Fa. The intraocular pressure IOP is proportional to the pressure applied to the globe. In practice, the cornea and the thickness of the wall of the globe, i.e. the thickness of the cornea, which is variable. The human eye, however, is not an ideal sphere. The cornea is rigid and resists flattening. Capillary attraction of the tear meniscus, however, tends to pull the tonometer towards the cornea. Corneal rigidity and capillary attraction cancel each other out when the flattened area has a diameter of 3.06 mm, as in Goldman tonometry Fig. 1.43a. The Goldman tonometer is an accurate variable force tonometer consisting of a double prism Fig. 1.43b. The tonometer prism should be disinfected between
patients and replaced regularly in accordance with the manufacturer's instructions. 2% Na hypochlorite dilute bleach offers effective disinfection against adenovirus and herpes simplex virus. However, disinfectants can cause the tonometer tip to swell and crack with time, which can lead to disinfectant entering the tonometer tip resulting in a corneal abrasion when applied to the cornea. 70% isopropyl alcohol wipes do not offer protection against viral infections. Disposable tonometer prisms and caps have been introduced to address concerns of infection from reusable prisms.
Technique: topical anesthetic, commonly proximethicane 0.5%, and a small amount of fluorescein are instilled into the conjunctival sac. The patient is positioned at the slit lamp with his or her forehead firmly against the headrest and instructed to look straight ahead, often at the examiner's opposite ear, and to breathe normally. With the cobalt blue filter in place and illumination of maximal intensity directed obliquely, approximately 60 degrees, at the prism is centered in front of the apex of the cornea. The dial is preset at 1, that is 10 mm of mercury. The prism is advanced until it just touches the apex of the cornea, figure 1.44a. Viewing is switched to the ocular of the slit lamp. A pattern of two green semicircular Meyers will be seen, one above and one below the horizontal midline, which represent the fluorescein-stained tear film touching the upper and lower outer halves of the prism. Meyer thickness should be around 10% of the diameter of its total arc, figure 1.44b. Care should be taken to horizontally and vertically center the Meyers so that two centralized semicircles are observed. The dial on the tonometer is rotated to vary the applied force. The inner margins of the semicircles align when a circular area of diameter precisely 3.06 mm is flattened. The reading on the dial, multiplied by 10, gives the IOP in mmHg. Sources of error: inappropriate fluorescein pattern. Excessive fluorescein will result in the Meyers being too thick, with consequent overestimation of IOP. Insufficient will make the semicircles too thin, with consequent underestimation, see figure 1.44b, left and center. Pressure on the globe from the examiner's fingers, eyelid squeezing or restricted extraocular muscles, for example thyroid myopathy, may give an anomalously high reading. Central corneal thickness, CCT. Calculations of IOP by Goldman applanation tonometry (GAT) assume that CCT is 520 micrometers, with minimal normal variation. If the cornea is thinner, an underestimation of IOP is likely to result, and if thicker, an overestimation. Corneas tend to be thicker than average in individuals with ocular hypertension, and thinner in normal tension glaucoma (NTG). Following refractive surgery procedures, the cornea is both thinner and structurally altered, leading to an underestimation of the IOP. Some 1 figure 1.45 tonometer calibration bar in position methods of IOP measurement, for example DCT, see below, may reduce the effect of structural confounding variables. Other corneal mechanical factors may also be important but are less well defined. Corneal edema may result in artificial lowering of IOP, hypothesized to be due to a boggy softening. The associated increased CCT seems to be more than offset. Astigmatism, if significant, may give distorted Meyers as well as leading to mechanically induced errors. If over 3 diopters, the average reading of 2 can be taken with the prism rotated 90 degrees for the second, or optimally the prism is rotated so that the red line on the tonometer housing is aligned with the prescription of the minus axis. Incorrect calibration of the tonometer can result in a false reading, and calibration should be checked before each clinical session using the manufacturer's calibration arm, figure 1.45. Wide pulse pressure. It is normal for there to be a small oscillation of IOP in concert with the rhythm of ocular perfusion. If this pulse pressure is substantial, either the midpoint or the highest level observed may be taken. Repeated readings over a short period will often be associated with a slight fall in IOP due to a massaging effect on the eye. Other factors include a tight collar and breath holding, both of which obstruct venous return, can raise IOP. Tip: the Goldmann tonometer loses accuracy with constant use and should be checked for calibration error on a regular basis. Other forms of tonometry, pneumotonometry, figure 1.46a, is based on the principle of applanation, but the central part of the cornea is flattened by a jet of air rather than a prism. The time required to sufficiently flatten the cornea relates directly to the level of IOP. Contact is not made with the eye and topical anesthesia is not required, so it is particularly useful for screening in the community. The sudden jet of air can startle the patient. Accuracy is improved if an average of at least 3 readings is taken. Portable applanation tonometry. Perkins uses a Goldmann prism in conjunction with a portable light source, figure 1.46b. It is handheld and can therefore be used in bed-bound or anesthetized patients. Dynamic contour tonometry, DCT, for example Pascal, uses a solid-state sensor and a corneal contour matching surface, with the aim of measuring IOP relatively independently of corneal mechanical factors such as rigidity. It is mounted on a slit lamp in similar fashion to the Goldmann tonometer and IOP is shown on a digital display. Studies comparing DCT and GAT IOP readings with manometric intracameral IOP seem to confirm DCT is providing a more physiological measurement. Electronic indentation applanation tonometry, for example Tonopen figure 1.46c, is a handheld electronic contact tonometer, a modified version of the older McKay-Marg tonometer. The probe tip contains a transducer that measures applied force. Besides portability, its main advantage is the facility to measure IOP reasonably accurately in eyes with distorted or edematous corneas and through a soft contact lens. Rebound tonometry, for example iCare figure 1.46d, involves a 1.8 mm plastic ball attached to a wire. Deceleration of the probe upon contact with the cornea is proportional to IOP. Anesthesia is not required. The instrument can be used for self-monitoring, a tailored personal version is available, and for screening in the community. Indentation impression tonometry, for example SHIOTS, is a seldom used portable device that measures the extent of corneal indentation by a plunger of known weight. Implantable tonometers are under development and if a clinically workable device is realized should facilitate accurate lifelong 24-hour IOP measurement. Ocular response analyzer and corneal hysteresis. The ocular response analyzer, for example Reichert, utilizes air puff technology to record 2 applanation measurements, one while the cornea is moving inward and one when the cornea returns to its normal position. The average of these 2 IOP measurements provides a Goldmann correlated IOP measurement. The difference between the IOP measurements is called corneal hysteresis figure 1.47. Corneal hysteresis is not a measure of the stiffness of the cornea, but rather a measure of how corneal tissue absorbs and dissipates energy during deformation and return. Corneal hysteresis appears to provide a measurement of IOP that is less affected by factors such as previous laser refractive surgery. It also offers information on which patients with glaucoma are more likely to progress. Patients with a low hysteresis value are at a greater risk of glaucoma progression, and it may serve as a biomarker to aid glaucoma case detection. There is also a strong relationship between corneal hysteresis and the magnitude of IOP reduction with topical prostaglandin therapy.